6 major bone health organizations just put out a joint position statement on a type of osteoporosis that almost nobody talks about. The kind that can show up during or right after pregnancy. And the reason it doesn't get talked about is genuinely frustrating. So we're getting into it today.
Hi there, I'm Tony Lee, and this is Hot Flasher, your daily menopause podcast that serves up fresh news, research, and wellness tips. I've built a daily news pipeline to find the latest on women's health and menopause research. Allow me to introduce my co-host, Nykki, who handles the headlines. Take it away, Nykki.
Thanks, Tony. We've got a genuinely interesting one to end the week on. Let's get into it. 3 studies dropped this week, all sitting in the bone and heart corner of women's health research. And together, they make a pretty compelling case that we've been framing some of these problems too narrowly. We'll start with cardiovascular health, move into a major new consensus document on a type of osteoporosis that almost never gets diagnosed properly, and then finish with a calcium question that I suspect a lot of you have been quietly wondering about for years. So, the cardiovascular study first. This one is from Lindsay, published July 17th in what looks like a large US-based data set of midlife women. The question the researchers were asking is one that the field has been circling for a while. Does where you live shape your heart health, even after you account for your individual risk factors? The answer, not surprisingly but still importantly, yes. Pretty substantially. The study looked at socio-demographic factors and what they're calling neighbourhood vulnerability. Things like poverty rates, access to green space, pollution exposure, housing quality, all the stuff that makes up the actual texture of where someone spends her life. And they found meaningful associations between living in a more vulnerable neighbourhood and worse cardiovascular health in midlife women. Now, the honest research credibility caveat here is that this is an observational study. You cannot pull causation from this design. Living in a high poverty neighbourhood and having worse cardiovascular markers could share common causes rather than one driving the other in a straight line. That's a real methodological limitation and worth sitting with. But here's my actual position on this. It almost doesn't matter for the practical conclusion because the associations are consistent across decades of research in this area. This is not a new finding so much as a more precisely measured confirmation of what epidemiologists have been documenting since at least the 1980s. Your zip code predicts your health outcomes. Midlife women in under-resourced neighbourhoods have higher rates of hypertension, metabolic disease, and cardiovascular risk. That pattern does not go away when you control for behaviour. What that means, and this is where I want to push back on how a lot of wellness content handles cardiovascular health for women in midlife, is that framing this as a lifestyle problem with lifestyle solutions is incomplete at best and condescending at worst. When the environment itself is working against you, individual behaviour change hits a ceiling. Telling someone to exercise more when there's nowhere safe to walk, or to reduce stress when financial precarity is the source of that stress, is not a health intervention. It's noise. This study matters because it adds to the pressure on clinicians and health systems to think structurally. The 5-minute appointment where a doctor tells a midlife woman to watch her diet is not going to move the needle if the grocery store is 4 miles away and she's working 2 jobs. That's a system problem. The research is increasingly clear about it. The second piece this week is a joint position statement on pregnancy and lactation-associated osteoporosis. They abbreviate it PLO, published July 16th, authored by Haji P, and co-signed by 6 major international organisations: the IAPM, the IOF, the ECTS, the ESCEO, the IMS, and EMAS. 6 organisations putting out a joint statement is not a casual thing. That level of coordination usually means the field has decided that the absence of consensus guidance has gone on long enough and is causing real clinical harm. PLO is exactly the kind of condition that falls through the cracks. It's rare, estimates vary, but it's not common, and it typically presents as severe back pain, often fractures, during the third trimester of pregnancy or in the weeks and months after delivery, usually while breastfeeding. The mechanism involves the enormous calcium demand that pregnancy and especially lactation place on the maternal skeleton. Most women recover bone density after weaning, but for some women, the bone loss is severe enough to cause fractures, and those women frequently spend months being told they have musculoskeletal strain or postpartum aches before anyone orders imaging. That diagnostic delay is the part that bothers me, because the clinical picture is actually not that subtle. A postpartum woman with severe spinal pain and vertebral fractures is a recognizable presentation if you're trained to look for it. The problem is that a lot of clinicians aren't. Osteoporosis in a woman who just had a baby doesn't pattern match the way osteoporosis in a 68-year-old does, so it gets dismissed or delayed. The position statement exists to change that. It gives clinicians a framework: who to screen, how to evaluate, what treatment options are appropriate, given that some of these women are still breastfeeding, and what long-term follow-up looks like, given the question of whether PLO increases fracture risk later in life. If you've had a pregnancy or postpartum period that involves significant back pain, fractures, or prolonged pain that was attributed to something vague, and you were never worked up for bone density, this consensus statement is worth knowing about and potentially worth raising with your doctor. It's not that your situation was PLO, it's that there's now a formal clinical framework your provider can reference, and that wasn't really true before. The other angle worth naming: PLO lives right at the intersection of reproductive medicine and bone health, which means it historically fell between specialties. Your OB wasn't thinking about your bones. Your future rheumatologist or endocrinologist didn't know about the postpartum history. This kind of cross-society consensus is specifically designed to bridge that gap. It's a good development. And then there's the calcium question, which feels like a Good Friday topic because it's something people actually do in their daily lives and wonder about constantly. The study, published July 17th by Papagiorgio M., is a longitudinal observational study looking at dietary and supplemental calcium intake in older women who were already on anti-resorptive osteoporosis treatment. Think bisphosphonates, that category of medication, and tracking whether calcium intake levels were associated with better bone changes over time. The finding that will surprise some people: more calcium supplementation did not consistently produce better bone outcomes in women who were already on anti-resorptive therapy. Dietary calcium intake showed a more favourable picture. The supplements, less so. Now, important caveats. Observational design, which means confounding, is a real issue. Women who eat more dietary calcium may simply have better overall nutrition patterns. The supplement finding doesn't mean supplements are useless. It means in this sample, additional supplementation on top of anti-resorptive treatment didn't reliably move bone density in a measurable way. That's different from saying supplements cause harm. But the broader pattern here is consistent with where bone health research has been trending for several years. The case for megadose calcium supplementation in women already on treatment has weakened considerably. The case for dietary calcium as the preferred source, dairy, leafy greens, fortified foods, fish with bones, has held up. The evidence base that a tool like open evidence would surface on this question increasingly points toward food-first approaches, with supplementation filling gaps rather than piling on top. What I find genuinely useful about this study is not the supplement findings specifically, but the fact that it was longitudinal. These researchers watched what happened to bone density over time in real women taking real medication in the real world, not a controlled trial environment. That kind of data has its limits, yes, but it also has a grounding that a short-term RCT sometimes doesn't. The practical read for a Friday afternoon: if you're on medication for osteoporosis and you're also taking a substantial calcium supplement, this is worth a conversation with your prescriber. Not panic, a conversation. The supplement may be appropriate for you specifically. The question is whether the dose makes sense given your dietary intake and your treatment, and that's exactly the kind of individualized assessment that a 5-minute appointment should make time for, but often doesn't. Thanks for spending the week with us. If you're enjoying Hot Flasher, please hit subscribe wherever you listen. It genuinely helps people find the show. Have a great weekend, and I'll see you Monday.
That's our week. Thanks for listening to Hot Flasher. We'll be back on Monday. Have a great weekend, everyone.